Hi, I'm Reggie Hicks, and welcome once again to If You Are My Brothers, the podcast. I am the producer of the documentary and outreach project, If You Are My Brothers, and this podcast is a part of that initiative. And we are all about having prostate cancer conversations. So we want to welcome everyone watching on YouTube, LinkedIn, Facebook, or if you're listening on your favorite podcast platform. We want to thank you for being here. Thank you for engaging with us. Now, today's episode, and it's titled Let's Talk About What No One Talks About. That is ED and incontinence. That happens after prostate cancer treatment for some. Now, we'll explore these two post treatment. Well, right for now, we'll call them side effects. We're going to ask our guest about that in a few minutes. The side effects of prostate cancer treatment, namely erectile dysfunction and urinary incontinence, right? We all have heard about these two things. So we're going to talk about the medical explanations for these side effects as well as coping strategies and rehabilitation for patients like myself that we may take. So whether you're a survivor, a caregiver, or just want to hear more about this particular issue, then you're at the right place. Now, in men in particular, you know how we are. We are often reluctant to discuss this. So, this particular conversation is for you. You can join us in the chat, you can ask questions, or you can just sit back and listen and hopefully engage us that way so that we can really just give you more information, but also make you feel at home. Now, before we dive in, just a quick reminder this podcast is not a substitute for your medical team. The opinions and medical issues we discuss are not a replacement for treatment. Now, you want to always consult your healthcare provider for any healthcare needs. We do call this series Prostate Cancer Conversation. So I want to invite you to join us in the chat, as I mentioned before, with your questions and comments. Don't be shy, right? We always say this is real life. And speaking of real life, I'm coming to you in a time zone that is right now about 1 a.m. in the morning. And also, I have caught some kind of bug, not COVID, but some kind of nasal thing going on. So just bear with me. It's early in the morning and I'm not feeling the best, but I'm here for you. And we want to ask you to remember to like, share, and subscribe as we go on this journey together. Now, to learn more about this podcast, and If You Are My Brother's documentary and community engagement project, we want to ask you to please visit ifyouaremybrothers.org. Again, that website is ifyouaremybrothers.org. Now, I'm honored to be joined today by Dr. Cara Cimmino. Dr. Cimmino is an associate professor of urology at Emory University School of Medicine, and she's been practicing urology since 2012. She completed a fellowship in men's health, focusing on quality of life surgeries and treatments for men, including testosterone replacement therapy, erectile dysfunction, male urinary incontinence, which we're talking about, and symptoms of BPH or an enlarged prostate. She actively engages in teaching and education and serving as associate professor of urology at Emory University and mentoring both medical students and urology residents. So I want to welcome Dr. Cimmino to If You Are My Brothers. Dr.
Hello.
Cimmino, welcome.
Thank you. Good to be here.
Thank you. Thank you for joining us. I know you're not new to podcasts, so as I mentioned before, this is just a conversation, and I'm really eager to learn um, more about these two things that can happen um, after prostate cancer treatment. So, just to talk a little bit about one thing I wanted to ask you right off the bat, we put in the copy, um, we call them side effects. Would you consider these two things side effects from surgery or prostate cancer treatment?
That's one way to put it, or basically we say risks, right? So when we talk about risks and side effects, often side effects you kind of think of with medications, I think more so
Right.
than surgery. So more of a risk, of the surgery that these things can happen.
So let's talk about what is erectile dysfunction and what is urinary incontinence, because they seem to kind of go hand to hand, at least for me. they,
Well, so they honestly they don't go hand in hand usually, but in prostate cancer, again, they're both risks, and a lot of people are affected by both during their treatment or after their treatment. Erectile dysfunction, essentially, it means you're not able to get an erection firm enough for penetration or for you to have the relations that you want to have, whatever they may be. Um, so that's sort of our definition, because some people have function that works for them. So it's basically, it's not functional to the point where you're happy with it.
and how common are these? I read or heard someone was telling me, and I don't know if it's true or not, that you have more of a risk of this happening when you have your prostate removed versus seeds or some other treatment. Is that true or?
It's true. And every individual surgeon might give you different numbers on what their personal, risk is, based on their numbers. But for the most part, if I'm counseling patients, when I get a prostate biopsy back and find out that someone has prostate cancer, and we're talking about surgery versus radiation versus surveillance, I say with prostatectomy, 90% of the time you're going to have some negative impact on your erections. And that may not be not inability to get them at all, but if you're not already taking Cialis or Viagra for other reasons, prior to your surgery, likely, 90% chance you might need it to assist. If you're already taking Cialis or Viagra at baseline, you might have a worsening of that. So I tell people it's certainly not going to get better. It may remain, stable, but more likely than not, you're going to have some negative, impact on it. And with radiation, I quote that more like 50 to 60%.
Hmm. Is there a treatment that where it's above that, or is it primarily around 50 to 60 when you look at it overall?
Well, it's around 50 to 60. And the reason I say that with radiation is that it might not happen right away. But the difference between surgery and radiation is surgery, you kind of within the first year and a half, you have recovered what you're going to recover. With radiation, the effects can be delayed. And a
Mhm.
lot of people don't understand that you get the radiation. It's from what most patients tell me, it's much easier to go through in that period when you're getting radiated in terms of side effects and things like that than the surgery and the recovery physically from surgery. But the radiation effects kind of can happen later, and further down the road. And so, again, it's hard to say how much of the erectile dysfunction that comes later is from the radiation itself versus
Mhm.
other medical things that might have happened otherwise, or age, related erectile dysfunction. So that's why it's kind of hard to put that, it's
That's right.
right. It's hard to gauge. So immediate erectile dysfunction, relatively low, but over, a window of time, effects from the radiation will likely, negatively impact your erections.
Yeah, because I was kind of surprised. I mean, because in my situation, I had no issues anytime, didn't take anything. So I think the prognosis was kind of good about, it would be, um, I would be, I would lose maybe some, but not like everything. So that's why I was a little surprised when it was a
When that
little,
happened.
yeah,
Hmm.
when that happened, because I didn't have any problems. Eh, but can patients do anything to like mitigate the side effects or the risk out of treatment, or there's kind of largely beyond their control?
I mean,
Would you
honestly,
say?
it's mostly beyond your control other than the normal things. And again, if you didn't have, erectile dysfunction before, you would have been in a pretty good position, hopefully, but it doesn't mean, as you know, that
Right,
it won't happen.
right,
But all the things, healthy lifestyle, if you have diabetes, making sure your blood sugars are under control, all the other things that contribute to erectile dysfunction in general, if you can kind of control that, that's essentially what you can do to sort of increase your chances, keep a healthy weight and things like that. Cause, all those things contribute. This is
yeah,
both with stress incontinence, also, stress with incontinence, which we can, we'll talk about a little bit too, or a lot bit.
yeah,
But if you have an increased belly, it can put pressure on your bladder. And that can make it a little harder to maintain continence too. So it's just the healthy lifestyle things. But honestly, it's nothing anyone, people will often say, even with getting prostate cancer, did I do anything? Is it anything I did? And the answer is no. More likely than not, it's either genetic or just a fluke. It's just the most common, prostate cancer that a man can have, just like breast cancer for women. It's nothing they did. It just,
Right.
it's unlucky, and you want to catch it early.
And it sounds that if you want to really kind of help, if you can mitigate, just be in good shape, right? I mean, lose the
Yeah.
weight. And it will, let me ask you about incontinence. You mentioned the weight issue, and I
Mhm.
have a weight issue that I'm working on. If I start losing the weight, would that help even now after all these years? Would that help
It
incontinence?
might, to some degree. So losing weight, again, it's that pressure on, the incontinence that people have from, prostatectomy is often because your sphincter. So we'll do a lesson if I'm allowed, but
Yeah,
basically,
yeah, absolutely.
men have two urinary sphincters that keep you from leaking when you pee. And so when you cough, those squeeze so that urine doesn't just come shooting out. With women, we only have one. So a lot of times when women are pregnant or after a baby, we stress that sphincter out, and we can leak when we cough or laugh or sneeze or bend over or
Mm-hmm.
things like that.
Mm-hmm.
And you can regain that too in similar ways that some men can, or get surgery for that. But what I always say is men are at an advantage at baseline because you have two sphincters. When you
Right.
remove the prostate, you remove one sphincter. So you're just like us women, you're dependent on one, but also, that can be stressed from the surgery as well. And so the stress of a belly, or that abdominal pressure, it's more weight
Mm-hmm.
being put down on your bladder. And so you're more likely to leak. So yeah, you can see some improvement with weight loss for sure.
Good.
Not, and it may not
And
make you totally continent, but it might
right,
improve it.
right. And you mentioned I had the, as far as incontinence, are there surgical procedures or something, or are there things you can do to help
Yes,
that if it's
absolutely.
really, can you talk a little bit about what that entails?
Yeah, so I mean, there's things that are minimally invasive, and then there's maximally invasive. So, again, the leaking that typically comes from, having your prostate removed is this stress incontinence we talk about when you cough, laugh, sneeze, bend over, those sorts of things.
Mm-hmm.
So you can do, and I often refer people for pelvic floor physical therapy, which is kind of like physical therapists. It sounds crazy, but it's kind of like physical therapists. You break your arm and you have to go through and do physical
Right.
exercises to regain that strength. These are physical therapy therapists that specialize in your pelvic floor muscles. And if you're doing those exercises right, like Kegel exercises is something
Mm-hmm.
both men and women will do. But people don't, I think, realize a Kegel exercise, if you're doing it properly, I can't see you doing it. You could be doing it right now talking to me. I could be doing it right now talking to you. And so some
Right.
people think that it's an exercise, if you're doing it right, oh, I'm squeezing all my, my muscles in my pelvis. I must be working that. And it's really a muscle you can't see. It's a muscle that when you're peeing, if you try to stop your stream by squeezing real tight, that's the muscle you want. And again, I could do that while I'm driving. I always tell people to
Mm-hmm.
stoplight, you can do those exercises, if you want to. But it's a couple of things with the physical therapy is it's, just like any muscle gain, you got to do it to see the effect, and you got to keep doing it to keep the effect. If you stop doing it, the benefit's going to go away.
Mm-hmm.
Um, and you have to make sure you're doing it properly. So pelvic floor physical therapy is something I definitely recommend, especially right up front with both, radiation if someone's having urinary symptoms, but certainly after prostatectomy, because that can help you kind of get back any muscle on your own, and there's no harm. And it's, same thing as, physical therapy for a broken arm. You go
Mm-hmm.
in regularly, they teach you how to do it, but then you're doing it, your homework is doing it on your own. You don't have to keep going in. So it's an input of time in the beginning, but not forever. So
Right.
that's, one option. In terms of management, let's say we don't want to go to the surgical options and things like that. There's lots of things to help manage collection of urine, right? So there's
Mm-hmm.
pull-ups, and there's pads of all different sizes, shapes, etc.
Oh, yes, I know.
Yes. There's condom catheters for some people, but that requires, wearing a leg bag. And
Hmm.
again, this is all different strokes for different folks, right? So it all depends on what works for you. There is actually something called an AFEX, AFEX, that is kind of like a urinal in your underwear. It's actually fitted to like a boxer brief, and where the cup is, there's actually like a little bit of a urinal that collects to a very small bag you
Oh.
can put on your leg. So instead of leaking into, a pad or a diaper, you're leaking into that and it's collecting, but it's not a whole long, tube, and it's not attached to your penis. So there's a lot of things that people have kind of come up with, but some of them don't work for people. Some don't
Hmm.
cause you maximal comfort. Similarly, there's clamps. So a Cunningham clamp is one, but it's basically a clamp, kind of like a barrette, really. This sounds,
Hmm.
again, terrible when I explain it to some people, but it works great for some people, right?
Right,
But it's
right.
literally just an extrinsic clamp. It's just putting a clamp on the outside of the penis. And so you put the clamp on when you're walking around, and it can decrease or stop your leakage. So I wouldn't wear it all the time. You can really irritate the skin. But if you're going to play golf, and you don't want to have to be dealing as much with pads, you can put that on and minimize the leakage. And then when you want to pee, you just unclip it, over the toilet and go to the bathroom. Again,
Hmm.
not comfortable for everyone. Again, so many brands on, Amazon or online. If you look up, male incontinence, clamps, etc., maybe something works for you. A lot of people are like, that's not comfortable, or their, penis isn't of a size or whatever that can manage having that
Yeah,
on
right,
comfortably. And that's real. But
right.
that's something you can do. So that's all the kind of non-surgical stuff.
I do have a question. Interestingly enough, of course, when you go on Amazon and you may type in incontinence, and then all of a sudden, you're getting these ads on social media, and it seems to be this new, um, like underpants or something, and it's you wear them and there's no leakage, and I can't even remember the name of it, but do things like that work? Tend to,
I've seen, or from patients also heard about that.
Mhm.
And there are, more absorbent. Basically, they're kind of reusable, essentially, diapers. So it's not that, it won't leak, but it absorbs better, and you can reuse them because it's expensive. I know, to buy
Yeah.
diapers or pads, and I mean that just gets costly. And so it's something that's more, it's just more reinforced. So it doesn't mean it won't leak. I mean, you can't just, ignore it and go on and
Right.
on. But
Right, right.
but yes, there are some underwear that are, purported, or, to be able to be kind of reusable like that, but feel more like, regular underwear. But I don't
And
know in terms of efficacy. I don't know. I haven't gotten
you're
full
right.
reports back.
Well, I'm gonna do. I was telling Danny I'm gonna do a show on this, and so like I can do like a what is it, incontinence hall? Like different clothes halls, the different pads, and
I like it.
um, be- because I use a shield
Mhm.
from the pins, the
Mhm.
front, and I went to that kind of after going through the proton treatment. But prior to that, I was kind of using, a female pad
Mhm.
from, I think Walmart. It was kind of a thin pad, but you cut it in half, and then, I can use it that way. And it was also not as expensive as some of the others, but I kind of went to a thicker pad. But I did have, I forget, somebody tell, I guess when I first had my surgery, um, I was told that if I didn't have wear a pad, that psychologically I would get better at like going,
Ah,
bit more, be more. I was like, oh, really? Well, I don't know. Tell the prostate that's not there that that's the
right.
case.
I don't necessarily agree with that, but I know, like, with, and again, not to compare to,
Yeah,
babies when
no,
they're
yeah,
getting, potty trained, but that's something, as a kid gets to like that toddler age where they're on the border and they're wearing pull-ups, that's something that sometimes they'll say to do, wear regular underwear because they don't want to be wet, and that'll, kind of push them over the edge where they don't have to be reliant. It's different in an adult who already knows how to, urinate properly. It's not within your control in this case. So it's, I hear that. I'm not sure that I would recommend that. You don't want
Yeah.
to be stuck in a situation where, you're uncomfortable. So,
Well, I have some stories, but I will say this just from a patient's point of view. After surgery or when the catheter comes out, just make sure there's a really thick pad that the patient leaves with, because I remember that happening to me, and I got a really thin pad, and I had no control. And my wife decided to make a couple of stops on the way home, which was probably not the best idea. After that, I mean, I had no control. Um, so we talk about that, but you did say there were some other surgical things, and we're going to
mhm,
get into ED in just a minute.
mhm.
Um, you said there were some surgical options
Yep.
if it really
So,
gets where you can't really control
yeah, and they range, right, on how much leakage you have. So often what, we use to ask patients about the leakage is, do you have less than 2 pads per day of leakage or more than 2 pads? And again, that's not perfect, but that sort of gives you an idea of quantity of leakage. If it's less than 2 pads a day, or you're wearing a liner a day or things like that, but you're just not happy with that, there's a really minimally invasive thing we can try. It doesn't always necessarily work, but it can. And it's macroplastic is what it's called, but it's basically a bulking agent. So like a collagen is sort of a good way to describe it, that you inject around where the sphincter is. So your sphincter, your urethra is circular. With this, you are asleep for it. So it is a procedure where you're asleep, but you can do it, under sedation like you'd have for a colonoscopy, not the full general.
hmm
And
hmm
you go in with a camera and we see, where that sphincter, muscle is, and you can inject in 3 points around it to just help it, we say coapt or stick together more, so it just plumps that area up. So there's a little more, pressure there. The benefit of it, I'm not cutting on your body. The recovery is super quick. Starting the next day, you can do anything you want to do once you've recovered from the anesthesia. Um, you might have a little blood in your urine, maybe an infection, can happen, but we give you antibiotics, during the procedure.
Right. hmm
But it's relatively easy to recover from and low risk. And it doesn't prevent you from getting any of the other things I'm about to talk about. It doesn't mean that you can't do that in the future if it's not enough.
hmm
So that's something in someone who has a little bit of leakage or leakage. Sometimes people have incontinence only when they orgasm, right? So I'm getting on the erectile, function
hmm
side of things, but climacturia, which is, peeing when you climax.
hmm
And that bothers them. And sometimes this will help with that. So I don't usually recommend it in someone who has more than 2 pads a day of leakage, because I don't think it's going to give the desired effect. But in this minimal leakage, it's worth a try because it's pretty easy to recover from and pretty low risk. Kind of moving on from that, any of the surgeries are a little more in terms of recovery. And the main ones we talk about are urethral slings and then an artificial urinary sphincter. Both of those are surgeries where, some people will send you home the same day, some people keep you overnight. But with both of those, we're making cuts. Um, and, you can't do any heavy lifting or strenuous activity, pretty similar to when you had a prostatectomy after those, 4 to 6 weeks, no heavy lifting, nothing too strenuous while you heal. The sling is, again, less difficult to recover from in that you urinate normally. So what it's doing is it's sort of, if your urethra is a tube, it's kind of putting a little hammock underneath it. And it's usually a mesh material, which a lot of the people you hear in the news a lot, you don't want to put mesh in your urinary tract.
Right.
It's a small amount. There's very minimal risk of erosion in men who haven't been radiated. So that's a key
Ah.
piece. So men who have been radiated, doing a sling really isn't a good idea because there's a higher risk of erosion of that sling through the urethra, which is just a terrible thing to have happen.
mhm.
But it basically creates like a hammock. So, again, pretty quickly right after the surgery, you should be continent. You'll already have that effect. Some people do too well. They have a little, swelling and need a catheter for a little bit and to let the swelling go down. But you still pee as you normally would. You feel full, you go to the bathroom, you pee. Again, that's also not really recommended if you have really heavy leakage. So I usually kind of stick to the 2 pads, per day leakage for
hmm
that.
hmm
Anyone who's more than 2 pads per day, honestly, the artificial urinary sphincter is sort of the gold standard. It's been around for years with improvements over time and continued improvements over time. But it's been around, for a long time. And with that, we're basically putting a balloon around your urethra on the inside. Okay, so where your sphincter should be doing its work, we're putting a balloon around there. And what happens is, again, if anyone hasn't heard, it sounds crazy, but it works very well. But it's connected to two things. Connected to a pressure regulating balloon, which is a pretty small balloon that we put behind your pubic bone through a separate incision. And then connected to a pump. And the pump is actually in your scrotum. So in the space where your testicles are, but next to your testicle. And when you want to pee, so when you're walking around, that balloon is filled with saline. It's filled with fluid and putting pressure on your urethra, just like an external cuff would, but on the inside, so you don't leak. When you want to pee, you go to the bathroom and you're not just going to be able to pee because that balloon is inflated, but you push the pump in your scrotum, which is really, it doesn't require too much effort. We try and position it in a place that'll be nice and easy to get to, but you push that balloon, and what it does is the fluid goes into the pressure regulated balloon for a minute and then cycles back in. So you basically have a minute to stand over the toilet and go to the bathroom, and then it closes up. If you don't feel like you're empty, you push it again, it gives you another minute. But you don't want to walk away before the minute's up because you might still be leaking.
Right.
So those are sort of the range, of procedures. And there's another procedure I'll just briefly mention, but it's very new, called ProAct, which is kind of a combo of the two, or not a combo, but it's adjustable. So the artificial urinary sphincter, we sort of have cuff sizes we choose. In the operating room, you kind of measure your urethra and pick a cuff to ideally not make it too tight, but make it tight enough that you don't leak. The ProAct is 2 balloons that are put in next to that sphincter area. So they don't go around it, they're next to it. The cool part about the ProAct, if it hopefully does what it says it does, but I'm a little bit skeptical. But the cool part is there's a port that's in this. So you pee normally. So it's still inflatable, but you don't have to push anything to pee, but it's adjustable. So there's a port in the scrotum that your doctor can, clean off and add fluid or take fluid out if you need to. And so that's a cool thing about it. So that if you get atrophy, sometimes, with the sphincter, the problem is that, you have pressure on there all the time. Over time, your urethra can lose a little bit of the muscle or bulk, and then, you might leak again. And with this, presumably you can inflate it more. It's a lot of information, I know.
No. This is great because I've heard a couple of the sling and maybe, but the new one, this is the first time I've heard about that. And that's when you say it's new, it's been around for.
It's about 6 years, I think, that it's been around. And to be honest, I don't do it yet, but one of my partners at Emory was on the kind of trial for it. And so she's been doing it. And sort of, again, mixed results, better results if someone hasn't had radiation than if they have, and things like that. So we'll see, sometimes with a lot of these new procedures, we get excited about them and then they don't have legs over time. But it's a good alternative, I think, but I still think, unfortunately or fortunately, the artificial urinary sphincter is sort of the gold standard on that.
Gold standard. And are these options available for someone like me, for instance, that's, it's been outside of the one, because I did have proton therapy, but the others, I mean, after 12 years of.
Nope, still can, so I mean, if you had minimal leakage and it had been 12 years and you hadn't had radiation, a sling would be an option for you, or macroplasty. So timeline, there's not a timeline on it.
Okay, gotcha. Yeah, because I'm averaging pretty much 1 pad a day. 2 if I get into a situation where, it's just crazy and I can't, and I keep an extra pad with me all the time.
Yep.
In all of my backpacks and in the car, and I got them stashed everywhere because you just never know.
Yeah.
And that's because once you get caught without one, then you say to yourself, okay, that's not going to happen again. I
Yeah.
make sure that I got to have them all over the place.
Well, and I don't know with you, I don't know how much you share on here or not, but like, have you ever tried a clamp or something like that?
No, I haven't.
Mm-hmm.
No, I haven't. But and the reason I'm asking too is, I guess we could kind of get into now the ED portion
Mm-hmm.
of it. You had mentioned about like urinating, when you have an ejaculation, because you don't have other fluids coming out.
Right.
And so when that happens, is your partner more susceptible to like any kind of
No, urine is, yeah.
infection or anything
No,
like
no.
that?
Urine is sterile for the most part. So no. And also urine, even if you did have a urinary tract infection, it's not transmissible like that. So no, that's
Oh,
not a
okay.
problem. Yeah.
Okay. Wow. Yeah, that's something I was kind of on my mind. So
Yeah.
thank you for that. So as we get into this ED thing, I
Mhm.
have to ask you about the commercials that I hear
Mhm.
every single day on particularly the sports stations,
Yeah.
um, about coming in, excuse me, and you hear the commercials, you come in, you'll see um, results the first day.
Yeah.
And no matter what your situation is, we can make it happen.
Yeah.
So what are they doing? And my goodness, I had been, but that just sounds
So,
like this is a wonderful thing.
well, yes, and right. So what they're likely referring to is what we call intracorporeal injection therapy, or intracavernosal injection therapy. ICI is what we call it. And more often than not, that's what they're referring to. So I'll back it up. We all know the Viagra and the Cialis and things like that.
Mhm.
So that's one option. That depends on your brain being excited. So it depends on your brain saying, "Hey, I want to have sex," and then signaling through your spine and nerves and everything else down to your pelvis to let things release, to let the blood flow kick in. Okay.
Mhm.
Um, the trimix or bimix, or there's a bunch of different types depending on how many medications you put in. So alprostadil is a one agent thing,
Mhm.
and you can buy that commercially. Edex or Caverject used to be
Right.
available. Then there's bimix and trimix. They can only be made by a compounding pharmacy, so a
Mhm.
specialty pharmacy. And then there's quadmix, which adds a second, a third, or a fourth agent. But all of that it's directly injected into the penis. And I know that sounds terrible as well, but it's a real thin needle. So it's the same needle you use for Wegovy or, diabetics who do insulin injections. So it's really thin. So most men, 99% of men who learn how to do it, usually are very anxious about doing it. And then they do it and they're like, oh, okay, that didn't hurt. But you just have to get over that mental hurdle. But what it's doing is you're injecting directly into the erectile body or the cavernosal tissue.
Mhm.
So you're skipping the brain part and you're skipping all of the signals having to go down, which have been disconnected or interfered with radiation or with prostatectomy in most cases. So you're just going to the erectile body itself and injecting these blood vessel dilators. And
Mhm.
that acts to have blood go in. So it takes about 10 to 15 minutes to kick in. But that's usually what we would, expect. So I usually say when I'm training patients on it, I say, inject and then foreplay for 10 to 15 minutes, and then you should have an erection. The thing with that is it doesn't always work on everyone, and the dosage is totally different for each person. And so when you go to those places and they say it'll work for everyone, well, it probably will work for a lot of people, um, but not everyone. And you would need to be really cautious with those about how they dose it, because if you get too strong of a dose, you get that priapism, which sounds wonderful when you haven't had an erection in a while, but it's really painful. And that's an erection that lasts more than 4 hours, right? Sounds fantastic right now.
Yeah.
Definitely
Right.
not. And lands you in the emergency room. So the risk with those places, so that's usually what they're referring to when they're saying we can get anyone an erection, because most people, this works, it's much more potent than a pill. But
Right.
again, doesn't work for everyone. And the thing I caution about with those places, a lot of times there's very minimal physician oversight and things like that. So you just want to be first of all, they make their money off of the medication they're giving you. That medication doesn't need to be $2,000 or $3,000. The pharmacies that we get it from are about, 125 for
Mm-hmm.
what would be the equivalent of 10 to 25 uses. So they're making their money
Mm-hmm.
off of their pharmacy that they have and charging you for that. So if you go to one of those places and it works for you, like you shouldn't have to keep buying that for that cost.
Right. Right.
And a lot of people get sucked into that. Yeah.
Yeah, I was going to say I tried that, and I did have, and I know that the dosage part is very, very important,
Mm-hmm.
and you kind of got to try it out to see what, because I did have one where it almost didn't go 4 hours, but man, I tell you, when it went to almost three, and it was not fun.
Yeah.
And but my only, I guess I just had some reluctance of the injection part, and I always wondered, why can't we just have an injection like a pen, as opposed to, and is that available now? Because when I tried it, it was still, I had to pull the dosage out, and
So
um,
yeah, that there are auto injectors that you can sort of purchase and load the needle into there. So you still usually have to draw it. It's not preloaded.
mm,
Again, because everyone's different with the and by the way, I'm sorry if you hear my dog crying in the background. My
that's
dog really wants me to
that's
walk her. I'm
well,
sorry.
tell your dog. What's your dog's name?
Marley.
Marley. We'll be done in a few. I get it. My dog would have been doing the same thing, but
Yeah.
he's in Atlanta, and I'm thousands of miles away. So,
Yes.
um,
But yeah, so you still have to draw it up yourself, because the preloaded, the dose is different for everyone. But they do make auto injectors that you can then load it into and push a button and it will go. I really prefer, when I'm teaching someone at least, to use the regular needle, because when you're injecting, the needle needs to be hubbed. As I say, you need to see no part of the needle out. Otherwise you might be
mm,
too superficial. And so people have a tendency with the auto injector to, like, or even when they're injecting themselves, to pull back, as they're pushing in.
excuse me.
And then you're going to get it in the superficial, not where you want it. And then if it doesn't work, it may not be because it doesn't work for you. It might be because it's,
It's just not right.
it's a operator failure, not medication
Right.
failure.
Right.
So
Right.
I
Right.
prefer teaching with regular needles, but they auto injectors exist. And again, when we
And
teach, oh, go ahead.
no, no, go ahead. Go ahead. Go
I was
ahead.
gonna say, when we teach you in the office, you come in again, so we prevent issues from happening. We teach you right and wrong place to inject. We welcome your spouse, your partner to come, if you have a partner, so they can learn too, because
Hmm.
sometimes a partner will be the one to inject.
Hmm.
We teach you the right and wrong place to inject. We observe you doing the first injection, and then we wait the 10 to 15 minutes to see what response you get. And if you get a 10, we want to make sure it goes away in an appropriate amount of time. So we don't let you leave with a 10. We want to
Right.
make sure it goes away, because we can give you a reversal agent if we need to, and then we would tell you to start at a lower dose. Likewise, if you get on my 1 to 10 scale, I say 1 is not, flaccid, 10 is fantastic, 6 is maybe I could penetrate. So let's say you get
Hmm.
a 6 with the dose we do. I say, okay, well, when you go home, you can try 5 units higher. And if that doesn't work for you, the next time you go to do it, you can go up by 5 unit increments slowly, so you're not in the ear.
Yeah. uh, I got that. So for me, I do remember after surgery, trying to figure out what was going on, and I, there was not really. I was given a lot of things to do,
Hmm.
but there was not really an assessment of kind of what was happening, how much blood was actually, like, and so, but I did finally find someone that kind of gave me an assessment, and said, here's where you are, here's, where you can be. I think
Hmm.
injections was something that I started, and have kind of started and stopped over time.
Hmm.
But for someone who, is coming out of this, is there a way to say, some assessment to talk about, or look at the blood flow that's
Well,
happening?
there is a procedure called a penile Doppler ultrasound, which is an
Hmm.
ultrasound that you do of the penis before, and then you give them an injection. You give a patient the injection, and then you assess after. To be honest, I don't use it that often, because the patient themselves is more the gauge. It doesn't change what I'm going to offer per se. So I usually don't like to do procedures if it's not going to change my recommendation. And so I do that if someone has penile curvature for other reasons to assess it. I rarely do it for, erectile dysfunction by itself. I sort of say, okay, try the pills. Did the pills do it for you? No. Let's try the injections. Try the injections. If they don't work, and this is where we move on, you can do surgery, and it just depends on you and how much you want to have penetrative intercourse. We can do surgery where we put in a penile implant, which is a device that you can put in that there's malleables, which are kind of, I say, like a gooseneck lamp. They're just, you have two erectile bodies. It's two rods that are kind of put in the penis. They are always firm, though. They don't go down or up. They're just always firm, and you can bend them like a gooseneck lamp, and straighten it when you want to have sex where you want it to go, and bend it in your waistband. So it's very simple, but it always stays firm. Versus an inflatable one, which is similar to the artificial urinary sphincter I talked about, where there's a pump in the scrotum and there's a reservoir that's behind the pubic bone. And when you want to have an erection, you squeeze this pump in the scrotum and the fluid fills those cylinders. And when you're done, there's a release valve on that scrotal pump, and the fluid comes out and goes back into the reservoir. And so it's a little more like a real penis would be, flaccid and not. But those are surgeries, and, there's risks with that and recovery from that too. So it all depends, and I tell people, they're like, well, what, should I do? And I'm like, well, what are your goals? If you're happy being intimate in other ways, or if your partner is, postmenopausal, if it's a woman or whatever, and they're not interested, that's okay. You don't have to do this. But if that's a goal of yours, here's what we can do.
Are there any myths or misunderstandings about ED or incontinence that you wish patients and even their partners better understood?
Well, I just hate when people come in and say they didn't realize it could happen. That makes me really sad. When there's not a discussion, and it might have been discussed too, but you have so much coming at you when you're trying to decide this and you have the diagnosis. And so it's possible that it was mentioned, but it wasn't the thing you were focusing on. But when people come in and say, I didn't know this could happen. And I wish I had never done X, Y, or Z because I didn't know that this was something that could happen. So it's not myths. It's the, I hate that for someone, right? To not expect it and have something that's such a quality of life alteration.
Wow. Yeah. That's deep. How do you approach in that situation? Just how do you approach building trust with your patients, and particularly men? I mean, we feel embarrassed or ashamed to kind of discuss the side effects. As I talk to men, and I can tell when they don't want to talk about it because it's just so, what happened and how are you feeling? Oh, everything's back 100%.
Yeah.
And I was like, okay, well, that's great that that's happened, but you could tell that they just don't want to even talk about it.
Yeah.
But they give you that 100%, no change. I'm back at it. No, not a big deal. And I know that may happen at some point, but with some folks, but so how do you build that trust to be able to say, let's talk about this?
Well, I mean, and by the time patients are coming to me, so I think my partners I don't do the prostatectomies myself, so I don't love robotic surgery. I like all of this aftercare, but I think my partners are pretty quick to refer, right? So if someone's saying, they ask these things, and hopefully doctors do after how are your erections, how's your urination, etc. And if there is something that's not satisfactory, they'll send them, to me or one of my partners who specializes in this. So you're already usually I'm getting people who are coming to me knowing what they're coming to me for. But I'm pretty direct once you get to me, where I say, okay, you're here for erectile dysfunction. Let's jump in. And, some people will say, oh, how did you get into this as a woman, et cetera. If someone is shy about it, I just say, don't think of me as male or female. I'm your doctor, and this is what I specialize in. And I'm not looking at you like that. I'm looking at how can I help you?
Right.
And so I also think it's disarming for people we're comfortable talking about it. We do this all the time. We're not embarrassed.
Right.
So to just jump right in, and I'm like, all right, on a 1 to 10 scale, what are you getting right now?
Right.
And so I think that's how you kind of approach it from our perspective. This is what we do.
Hmm.
So don't feel like you can't talk about it with your doctor. This is what we do. We want to help,
Right.
but we can't help
How
if we
much,
don't know.
if you don't know, and how much would you say? I know a lot of it is obviously physical. What's the psychological part of all of this? Are there some psychological things that maybe that come into play when you talk about incontinence and ED and those kinds of things?
Well, 100% there's psychological, I mean, the impact it has on you, right? I mean, there are lots of
Hmm.
people who, when we're talking about what we want to do to treat, they're like, I don't go out anymore. I don't do these things. And that's causes depression, that kind of stuff. So there's, and I definitely am not equipped to do any of the psychotherapeutic,
Right, right, right.
options, but I certainly I have sexual therapists who are trained especially in, sexual medicine and things like that, that are regular therapists, but they also have an extra bent on that if that's a
Excuse me.
component of it. But there can
Hmm.
be, I mean, there can be a lot of shame. I mean, and there can be a lot of embarrassment and all of those things. And there is a psychological component sometimes to the erectile dysfunction, not always. But whether you've had prostate surgery or not, if you're having trouble getting erections, your brain is powerful. And if you're worried about I say you're a man, not a machine, you know, uh, uh,
Mm.
provided you're not a teenager, you're a
Right.
man, not a machine. You need to be turned on. You need to have the input. And if your brain is saying, oh, what about that work I had to do? Or, oh, no, I'm not satisfying her. Oh, no, it's going to happen again. It's going to shut it down. So there is a
Hmm.
psychological component too, both to getting an erection, but then the negative, the psychological impact of going through this. This is a lot. So
Yeah,
again,
yeah.
there's support for it, but yes, it's real. I mean, 100%.
So as we close out, I have a couple of questions. So what message would you share with men who may feel that life after treatment will never be the same? How do you approach that?
I would say, it might not ever be what it was before in terms of how you get your erections or how you manage your incontinence, but we can help depending on how aggressive, you want or need to be. We can help you get, more continent. There's a lot of things you can do. And with erections, we can help you with that too. So it may
Mhm.
not be exactly the same, but we can get you a good quality of life. And again, it just depends on what your goals are. And, you know,
All right.
so I would just say that's not the case, but it's tough. And depending on how impacted you are, and if it's in both realms of erectile function or incontinence, or, it's a lot to handle, but there's a lot we can do.
Yeah, and I tell men all the time that don't focus on that. My wife has coined this phrase "life over libido." That there's so many things out there that can help you once you get past the initial part of this, which is dealing with the cancer in your body. So, don't focus. A lot of men focus on what are going to be the effects of this after it's all done.
Right.
Will I still be able to do what I did before? Um, and as we close out, are there things on the horizon? You talked a lot about what's out there for incontinence, which I didn't
Oh,
know,
my
which
dog
is
just
great.
went crazy.
Yeah, yeah, because you know what? She heard me say we got one more question, and it's like,
I
okay,
know.
well,
And
get
then she
to
went nuts.
it. It's
Oh,
like get to
Marley.
it. It's okay. It's all right. So, but when it comes to excuse me, ED, it looks like it's like Cialis or Viagra, and then there's uh, the shot, and
Hmm.
then there's the penile implant, and that's sort of and that was the way it was back 12 years ago. So is
Hmm.
it? It seems to be that's still the main three options today.
It's the main three options, and there are, a couple of other ones. There's a vacuum erection device that's been around forever. That's just purely mechanical, and a lot of men find that, unhelpful. But a lot of
Yeah.
men like it.
Oh, been there,
There's
done that.
Right.
Exactly.
But it's an option. That's not a medication or, a surgery. There's pellets as well that you can put into the urethra. They're just not, they're more expensive and less effective than the injection. So there are options, but no, honestly, there's not really, major developments at this point. I think if you go to those men's health places, there's a lot of talk about shockwave therapy for erectile dysfunction.
Yeah.
And I think that that's something that's being worked on. And I think at some point might be helpful for some people with erectile dysfunction. But at this point, it's not finely tuned enough to be the answer. And again, at this point, it's not FDA approved. So it's out of pocket payments and it's not cheap. So I do usually tell people it's not going to hurt you, but I'd probably save your money. But that's something new that they're kind of trying to work on. And again, I think it might be helpful for some, erectile dysfunction, maybe from diabetes or high blood pressure or things like that, but not necessarily a post, surgical, erectile dysfunction. But that's sort of and then there's also plasma injections, that they will advertise at these places. And that also is not ready for prime time. So, and they're expensive too.
You mean like plasma from
you
taking
take
plasma from you
and you process it and put it in, and that's very expensive and there's not good data to support that. So I also would caution people to kind of not do that.
So what I'm hearing, and I really appreciate Dr. Cimmino, you coming on and talking to us, and we're going to have you maybe come back as I can talk about my pads and everything else. So it sounds to me, and again, 12 years out, there's still things that I can do or have done to improve where I am even now, even after kind of dealing with this for over a long period of time.
Absolutely.
Is that correct?
Yeah, okay. Absolutely.
And for me, will doing the exercises help still even at this point?
Yeah, it might. I mean, and again, will it get you 100% continent? Although it sounds like your continence isn't, too extreme. So it could, but it might improve it. Yeah. So it's definitely not. And again, never harmful and potentially helpful.
Okay. Well, I appreciate anything else you want to tell?
I could go on forever. So, another time.
Yeah.
But thank you for having me on.
Thank you so much. Get your dog walk. But hang around for just a second now. So we still need to hang around. But thank you so much for being on. We look forward to having you on again and taking the time and just doing what you do is so important. So thanks again.
Thank you.
And we want to say thanks to all of our followers for sending in questions. We, excuse me, as I mentioned before, I'm kind of battling this, whatever it is, cough, respiratory, not COVID, but I got a bug. But I hope that we were able to give you some insight, excuse me, and then we also helped some folks who have had similar questions on their minds. And as I mentioned at the beginning of the show, that we're taking this journey together. So if this episode resonates with you, please share it with a loved one, like it, and subscribe. You can also contact us via email, social media, and even regular, as my wife likes to call it, snail mail through the Postal Service. All of this is on our website, ifyouaremybrothers.org. You can also sign up for our e-newsletter that comes out every other month. So we appreciate your support. And speaking of support, I want to remind you that If You Are My Brothers is a nonprofit 501c3 project dedicated to prostate cancer awareness, and as we like to call it, health action. We hope you will support us in what we do. And if Danny's standing by, he'll put up a slide with all of the giving options to keep this podcast continuing. Excuse me. So if you're listening to our podcast, the link is in our show notes. If you obviously can't see it if you're listening, so it will be in our show notes as well. And there's the QR code and the various ways that you can support what we do here at the If You Are My Brothers podcast. As I mentioned, the audio version of this episode will be available next Tuesday on Apple, Spotify, and all major platforms. And all of our episodes are archived on our YouTube channel as well. This episode is sponsored by Creators Nature Blend. It's a wife and husband team. They do pure natural herbal serums and oils and tonics, handcrafted with homegrown and wild crafted ingredients right out of their garden. So it's like farm to table kind of thing. And you can learn more about what they do at the creators natureblend.com. Again, that's the creators natureblend.com. So you got that. Now, here's some community prostate health activities that are going on this weekend. This Saturday from 1 to 4, Revision Church Atlanta and their strategic partnership ministry will be sponsoring a community health fair and screening. There'll be from free flu shots to free PSA screenings. Event is open to the public, and to register, you can visit revisionchurchatlanta.org. That's revisionchurchatlanta.org. And the Revision Church Atlanta is located at 999 Briarcliff Road Northeast in Atlanta. 30306 is the zip code, if you need to know that. The Strength and Courage Prostate Cancer Real Talk with DMOF is this Saturday. David Moffitt is a wonderful advocate. We're hoping to have him on the podcast at some point. But he's having this real talk with men and partners and family members Saturday from 10 to 2. And it's going to be at 1800 Parkway Place in Marietta, Georgia. So you can join that. I don't have a email or a website for that. But finally, yours truly will be interviewed on The Local Take with Kipling Primus, and that's this Saturday at 8 p.m. Eastern on 91.9 FM WCLK. Now, if you miss it, you're not up that early on Saturday, don't worry about it. You can always go to WCLK.com and listen to the archive interview. We'll have that link in the show notes as well. Or you can listen, and you can also, if you want to do it live, you can listen streaming live at their website, WCLK.com. Special thanks to our producer, Danny Garcia Pozo, and to Zach Reynolds at Borkhouse Productions for our opening. Now, remember, this podcast is not a replacement for medical advice. Always talk to your healthcare provider about your health. And we want you to join us for our next episode on Thursday, October 23rd at 7 p.m. Eastern. I'm hoping that by then I'll be all healthy and this cold or whatever will be gone away. And just remember this as we close out. If You Are My Brothers is a project of Straight Street Media, and you can learn more about Straight Street Media at our website, straightstreetmedia.org. And so that's about it. Until next time, if you are my brothers, remember to share this message and information. Take care, stay healthy. Peace.